Bhattad for the clues to primary immunodeficiency in clinic. And the panelist for this is Dr. Neeta Radhakrishnan, Dr. Mukesh Dhankar, Dr. Arpita Chattopadhyay, Dr. G.P. Kaushal, Dr. Ramesh, Dr. Sagar. Dr. Sagar is a consultant pediatric immunology and rheumatology and BMT at Aster CMI Bangalore. He is the director FPID Center for Excellence for Diagnosis and Management of Primary Immunodeficiency Disorders at Aster CMI Hospital. He is a secretary in Pediatric and Rheumatology Society of India. Now I welcome Dr. Sagar for the presentation. नाम बता दीजिए। अच्छा, chairperson के नाम। And the chairperson for the session is Dr. Lalit Tandon and Dr. Avijit.
Should we begin? Yeah. So, good afternoon and thank you organizers for having us here. I think this is one topic that needs to be discussed in every conference, and obviously when we talk about infections, immune deficiencies are something that we all must be thinking in our clinical practice. I hope people will quickly catch their lunch and come back to the hall. So, we'll have quick case-based discussion on immune deficiencies. And to enlighten us on this topic of primary immune deficiencies, we have eminent panelists, Dr. Ramesh, Dr. Neeta, Dr. Mukesh, Dr. Arpita and Dr. Kaushal. And that makes my life much easier because I am only supposed to ask questions. I must say that in the last decade there has been a very phenomenal change in the way we are looking at these diseases in India, thanks to the diagnostic facilities that are now available and even the therapeutic facilities. Now, the new term for primary immune deficiencies is the inborn errors of immunity, and the latest update says that there are at least 559 diseases. So when we talk about these disorders, it's not a single disease that we are talking about. And look at the advancement in science that only in the past 2 years, 67 new gene defects have been identified. So what it means is that possibly in the next 5 to 7 years, if this number crosses 1,000, one must not be surprised. So it is our responsibility to be updated so that these children are diagnosed in time and we can provide therapy. Now, to the audience here, well-learned audience, I think you must know that immune deficiencies as a group are 4 times more common than hemophilia and 5 times more common than cystic fibrosis. Unfortunately, in most of our medical training, whenever we talk about recurrent infections, say chest infections, CF is almost always discussed, whereas immune deficiencies are hardly discussed. I think if that is one thing that is done in the medical training, we will do a lot of justice to these young children. Now, how common are these disorders? They are not rare, and as a group, 1 in 1,200 people are said to be affected, and that would mean more than 1 million patients would be suffering at any given time point. This is not my statement, this is a statement from the Society of Primary Immune Deficiency. Well, these disorders have a broad range from mild to severe, and that is why the most milder ones may survive into adulthood without even knowing that they had an immune deficiency. Now, we'll not make it theoretical, we'll just have few quick cases. This would be completely case-based, real-life cases, and we'll ask our panelists to give their opinion on the same. Coming to the first case. This is an 8-month-old boy, as you can see in the picture. This young boy was unwell from 4 months of age, recurrent diarrhea. And because of each episode of diarrhea, loose stools, this child was given IV antibiotics, and there had been several courses of antibiotics so far, and the child was failing to thrive. Now, Dr. Ramesh, sir, recurrent diarrhea, what could be the causes? I think this is a broad field. Yeah.
First of all, let me thank you profusely for bringing me into this particular panel, because when I heard as a general pediatrician, I was worried that what I can speak. But after going through the presentation, I really felt that the figure 1 into 1200 you quoted. So when I bought my first camera, before buying my camera, I asked my friend who is an ornithologist. तो मैंने उसको बोला कि बर्ड्स तो इतने होते नहीं है तो फोटोग्राफी क्या करेंगे, तो उसने बोला कि यू बाय अ कैमरा देन यू विल सी द बर्ड्स. So 1 into 1200 means it is fairly common. So at the end of this presentation, I realized that now I will be able to diagnose, at least suspect more cases. So this is a 8 months old, and since last 4 months something is going on. So it's a fairly chronic process, and the weight has also been affected. So the photo showed that baby was having pacifier in his mouth. So first I will suspect mismanaged feeding, then the malabsorption syndrome. And cow's milk protein allergy, one of my friend 1 year back, he told me that even when mother is on cow's milk, then also baby has. So since last 1 year, I have been noticing and asking specifically that whether mother is also having cow's milk or not. And as we are dealing with this topic, immune deficiency, either it could be HIV or primary immune deficiency leading to recurrent infections. Thank you.
So I think this would be broad differentials as clinicians we all would be bringing at in our clinical practice, and many a times I think we definitely advise them to stop the bottle feeds. And I have seen very commonly the CMPA tests being carried out. We carry out those IgA and often we are lost. Now, end of the day, what happened was this child, by the time he reached us, there was perianal erythema and a fistula. And on further investigation, as you can see, there was remarkable neutrophilic leukocytosis, as I can see here. There was marked thrombocytosis. The platelet counts were as high as 10 lakhs. The ESR CRP were mildly raised. And then, because most of the stool cultures, blood cultures, everything was sterile, a fecal calprotectin was ordered by the gastroenterologist, which was remarkably elevated. I think the cutoff is 100, but then anything above 10,000 is quite significant. Over to you, Dr. Neeta, ma'am.
Yeah, so in a scenario of recurrent diarrhea and failing to thrive, one of the most common presentations from an immunodeficiency angle would be severe combined immunodeficiency, as well as another one would be chronic granulomatous disease. This is probably neither of those, but from a pediatrician's angle, whenever we are evaluating for immune deficiencies, all of you would have heard about the 10 warning signs, of which the most important would be family history and FTT, failing to thrive. So if it's a baby who is failing to thrive and not improving, the mother classically tells you that one egg diarrhea theek hua, ab agla shuru ho gaya. So that process happens because of chronic viral diarrheas especially. So that sometimes we may not be able to pick up because we are not, all of us are not running biofires and stools for these patients. So whenever that kind of a presentation is there, what I would look for in the CBC is lymphocyte count. I would look for absolute lymphocyte count, and if it's an infant, if it is less than 3,000, I will really keep that as a pointer to evaluate further. Another very easy investigation is immunoglobulin profile, and that also gives you a diagnosis very quickly if immunoglobulin levels are low. So an immunoglobulin low patient, absolute lymphocyte count low, then you straight away go to TB-NK subsets and make the diagnosis. You don't even need a genetic evaluation. The diagnosis can be made then and there. In this particular patient, so if you have a neutrophilic predominance, then if you have a chronic diarrhea scenario, then you will start thinking, is this an inflammatory process that is happening in the gut? So is there an inflammatory bowel disease that's happening? And like Dr. Sagar just told us, the calprotectin is very high. That is indicative of an inflammatory process in the bowel that is happening. From an immunodeficiency angle, this can still be immunodeficiency, either because of CGD or because of many other inflammatory monogenic IBDs which can come in this scenario.
So as rightly highlighted by Dr. Neeta, you can see that a gut biopsy, a colon biopsy was asked for, and it confirmed a Crohn's-like disease in this young child. Now, IBD in an infant, I am sure we are not talking of something common, we are talking of something very uncommon. What are your comments, Dr. Mukesh? Yeah.
Right. So a lot has been talked about this child, various causes of recurrent diarrhea, why we are suspecting immunodeficiency. So definitely we are dealing in a situation, it's an 8-month-old child, it's a small child, it's less than. So whenever we, in a small child, specifically when it is less than 6 years, we should suspect. It's not always what we classically read, 4 ear infections, 2 sinus infections in an ear, or 2 pneumonia in an ear, or failure to thrive, or just deep-seated infections, or 2 months of antibiotic. It's not always like that. Here, definitely we have recurrent diarrhea, that's one of the clues, but biopsy has cleared most of our issues. So it's an inflammatory bowel disease, probably of an immune, not immune origin, probably a genetic origin, where if it's in this age group, I would definitely suspect immunodeficiency. So there are various genes which are causative of this thing, and routine immunosuppressives are not beneficial, and so we have a genetic test report also with us which shows that we have a pathogenic gene, IL10RA gene, which is pathogenic, and it is suggestive of very early onset inflammatory bowel disease. So transplant is usually the thing which is going to help us.
Yeah, so this is something very interesting. I must say IBD, obviously we talk about pediatric onset IBD itself is uncommon when we compare to adults, because commonly it is the 3rd and 4th decade where you see IBD. Now we are talking about IBD starting in infancy or before the age of 6. This is called the very early onset IBD, and we all know IBD is an autoimmune disease, but the message here is when autoimmunity starts at a very young age, think of a genetic defect. And the approach for IBD in an adult is to give him or her immunosuppression, and many a times lifelong immunosuppression. But the therapy here would be very, very different. So whenever you have young children having autoimmune manifestations, you can think of monogenic disorders. Mutations in such genes can cause IBD, which is quite refractory to routinely used immunosuppressants. And then the problem here, I can just tell you that there